Okay, our next speaker is Dr. Lauren Steward, who will give a presentation on COVID-19 and kind of the overall surgical practice. By brief introduction, she did her undergraduate at Stanford University, MD, at Harvard, general surgery at WashU, and then came to Colorado to do the tax fellowship in the CU Denver Health combined program. I think you've seen her name and leadership a lot in various safety and quality programs at the University of Colorado Hospital and in the Department of Surgery. She's an excellent surgeon and excellent critical care doctor. I know that personally because she has saved a few of my patients who got into trouble post-operatively. And I really thank her for mentoring multiple trainees, general surgery residents in safety and quality programs. So with that, we look forward to your talk, and thank you so much.
Okay, thank you for the opportunity to speak today. I'm going to be discussing COVID and surgery. And so it began in December of 2019. A virus was identified in Wuhan, China that has since spread worldwide, leading to the COVID-19 pandemic. At this point in April of 22, nearly 28 months later, we have identified over 500 million cases of COVID in the world and over 80 million in the US alone. This has led to greater than 6 million deaths and nearly 1 million occurring in the US alone. And so what did this mean for surgical procedures in hospitals? This is a study out of Stanford. They used administrative claims from more than 13 million surgical procedures in 49 states, comparing the number of surgeries performed each week in 2019 with the corresponding week in 2020. And as expected, the researchers found a 48% decrease in surgical volume during the 7 weeks after mid-March, when CMS advised that hospitals minimize, postpone, or cancel elective surgeries. But we quickly ramped back up, and by July of 2020, the nation's hospitals and surgery rates began to return to or even surpass their 2019 levels. And so by the end of the year, the total volumes of surgery was only 10% below the 2019 volume. So what were the consequences of delaying surgery? From a hospital perspective, there was a backlog of cases. One estimate was approximately 5 million cases were backlogged. From a patient perspective, there was a progression of surgical disease with increasingly morbid operations, which may be associated with higher costs, reduced activity, mobility, or quality of life. And these are some of the thoughts from many of our patients. So this is a 45-year-old male with a history of liver transplant complicated by ventral hernia awaiting hernia repair. And he said, to have it taken away from you, it's kind of devastating. 33-year-old female and mother with epilepsy preparing for a 2-stage lobectomy. She said, I have been mentally preparing and physically preparing myself and my children for 6 months, and now what? And here's a patient that is probably near and dear to my heart, patients we saw in the ED all the time. 55-year-old male with symptomatic cholelithiasis awaiting laparoscopic cholecystectomy. If I go to the ED, are they going to turn me away and say, sorry, we have a bunch of coronavirus patients? And so the surgical case delays clearly impacted all of us. And at the early stages, it seemed obvious for the reasons why we decided to postpone surgery. It was to conserve PPE, to redistribute our healthcare personnel, and reallocate our work and OR spaces to deal with the overload of COVID positive patients. But later on, it may not have been so obvious. And so what I want to do over the course of the next few minutes is to discuss the data that led us to believe that it was in the best interest of our patients to delay surgery. But we have to look through this data through the lens of time. And so we're going to walk through kind of the early, the mid, and the most recent data on COVID and surgery. So as Dr. Wohlhauer pointed out, the first patient was identified in December of 2019 who developed respiratory symptoms in Wuhan, China. By January of 2020, the WHO had identified a new coronavirus, COVID-19, and the US had identified its first case. And by March of 2020, 13 Colorado counties had issued a stay-at-home order. And at this time, the US had restricted entry from various countries. Cruise ships were in quarantine. Italy had gone on lockdown, and the first cases were being seen in sub-Saharan Africa. And so this is one of the first studies that we saw. This study is out of China. It was published in April of 2020, where they reviewed the clinical data of 34 patients diagnosed with COVID-19 who underwent surgery in Wuhan, China, from January 1, 2020 to February 5th of 2020. All of these patients were diagnosed with COVID postoperatively. The median age was 55. They'd undergone a variety of operative procedures, spine, orthopedic, mastectomies, general surgery procedures, and they categorized them based on the level of difficulty of 1 to 4. Of those 34 patients, 44% required admission to the ICU, 32.4% developed ARDS, and their mortality was 20.5%. And that mortality occurred in patients who had the easiest cases at level 1 up to level 3. The next study came out of Italy. Again, this was a matched cohort study of general vascular, thoracic, and neurosurgery procedures out of a single center. Again, looking at cases that had surgery from February to April, these patients had a positive COVID test either 1 week before or 1 week after surgery, and they were matched with patients who were COVID negative. Again, COVID positive group was 20% and the control group was 2.44%. They saw pulmonary complications in 16.2% of their COVID positive group, and their control group was only the pulmonary complications were only 6%. They also saw higher thrombotic complications in their COVID positive group. Of note, there was no statistical difference in hemorrhagic, cardiac, neurological, or local complications. And then we finally got some data from a bigger study. So the COVID Surge Collaborative, this, like the Vascular Collaborative, is an international multi-center, multidisciplinary team with individual collaborators collecting data locally, which is collated centrally. I can happily say that the University of Colorado actually also contributed to some of this data under the direction of Dr. Catherine Velopoulos and Dr. Heather Carmichael. So this data includes data from 235 hospitals in 24 countries. And for this first study, they evaluated 1,128 patients who had surgery between January and March 31st, 2020, of which 834 had emergency surgery and 280 had elective surgery. And all of these patients were diagnosed with COVID within 7 days before or 30 days after their COVID, 30 days after surgery. They looked at 30-day mortality, and again, their 30-day mortality for these COVID positive patients was 23.8%. Mortality was associated with the male sex, age greater than 70, ASA grades of 3 to 5, a malignancy diagnosis, emergent surgery, and major versus minor surgery. Secondary outcomes were pulmonary complications, which included a composite of pneumonia, ARDS, or an unexpected postoperative inhalation. And the pulmonary complications in this particular group were approximately 51%. So 51% of these patients developed pulmonary complications. Sorry, excuse me. Okay, and so that was the early data that we had. But the pandemic, and so that's the data from early in the pandemic, from like January to April. But the pandemic went on, and so what happened to these patients who were in this late group of these patients from July to December? And these are the patients who may or may not have been actually recovering from COVID at this point. And so the question was, how do we resume surgery, and how do we determine the time frame for when surgery should restart? So at this point later in the pandemic, keep in mind that things had changed. You know, we had new variants identified in October of 2020, the Delta variant. At that time, we had noticed increasing COVID cases within the US, and also the vaccines were just coming out for healthcare workers. So this study, this is sort of the midpoint, I would say midpoint data. They're looking at outcomes of patients who are undergoing surgery after recovering from COVID infection, and they're from April 2020 to July of 2020. And they looked at asymptomatic patients that had their surgery delayed after preoperative PCR positive COVID test, and they are matched 1 to 2 with patients who had a negative pre-op COVID negative test. So they had 49 patients who had delayed surgery in the COVID recovery group and 98 patients who were in the COVID negative group. Median time between SARS-CoV infection and definitive surgery was 25 days. And the primary outcome was 30 days complications. And they just said it's based on the Cleveland-Dindo classification without actually specifying what those actual complications were. But in this particular group, so this is looking at asymptomatic patients who were delayed, they saw no statistical difference in complications, in either 30-day complications, pulmonary complications, or death within 30 days. But again, single center study. And so then we got more data from the COVID surgery collaborative. And I think you just have to remember, like during this time, like everyone's publishing whatever the best stuff that they can come up with. So we have these small studies that are saying one thing. We really had to wait for the bigger studies in order to actually get a sense of what actually is going on. And so I think the best data about outcomes in surgery is coming out of the COVID surgery collaborative. And in this case, this is the timing of surgery following SARS-CoV infection. They're looking at surgical patients with a preoperative SARS-CoV infection who were compared to those without a previous SARS-CoV infection who underwent surgery in October of 2020. So the data before was kind of April to October. This is now actually just October. And their primary outcome is 30-day mortality, and their secondary outcomes are postoperative pulmonary complications, which is a composite, again, of pneumonia, ARDS, and postoperative ventilation, unexpected. They had 140,000 patients from 116 countries, of which 3,100 were preoperatively determined to be SARS-CoV positive. As you can see, mortality decreased in patients having surgery further from their COVID diagnosis. So if you had surgery within 0 to 2 weeks from your COVID diagnosis, your mortality was 9.1%. Within 3 to 4 weeks from your COVID diagnosis, your mortality was 6.9%. And within 5 to 6 weeks, your mortality was 5.5%. And if you had surgery performed at greater than 7 weeks after your SARS-CoV diagnosis, you had a similar mortality risk to your baseline, to baseline of not ever having had COVID. In addition, they found that patients who had persistent symptoms of COVID at greater than 7 weeks also had a higher mortality than those who've been either asymptomatic or never had COVID. The pulmonary complications followed a similar pattern. And the conclusion at this point of this study in December of 2020 was that surgery should be delayed for at least 7 weeks following SARS-CoV infection due to an increased risk of 30-day postoperative mortality and an increased risk of 30-day postoperative pulmonary complications. And if you had ongoing symptoms for more than 7 weeks, you should be delayed even further, or at least considered to be delayed even further. This is a similar study that also looked at the VTE rates and came up with similar, also from the COVID Surge Collaborative, also came up with similar findings. They did find their control group was patients without SARS-CoV infections. The peri group was patients who were defined as having a COVID infection between 7 days before or 30 days after. Patients with recent COVID infections were 1 to 6 weeks, and patients who had greater than 7 weeks from their infection. Again, the further out you go from your COVID infection, a decrease is seen in your VTE rates. And overall, they found that if you had VTE, you had an increased risk of 30-day mortality, and that risk of SARVID plus VTE increased your mortality substantially. And so the recommendations as of March 2021 were that elective surgery should be scheduled within 7 weeks of diagnosis of COVID infection unless the risk of deferring surgery outweigh the risk of postoperative morbidity and mortality. And the time before surgery should be used for functional assessment, rehabilitation, and multidisciplinary optimization. Vaccination several weeks before surgery will reduce risk to patients and might lessen the risk of a COVID infection. But as I said, the pandemic went on. And so in the summer of 2021, we had the Delta variant that was identified. The vaccines were widely available for all patients, and we had got better at treating COVID, to be perfectly honest. And so this is the most recent data that's coming out. This was published in January of 2022. And this is the risk of postoperative complications after major elective surgery and active or resolved COVID-19 in the US. And so they looked at 18 different types of surgery: lung resections, esophagectomies, mastectomies, colorectal resection for cancer, prostatectomy, Whipple's, gastrectomies, etc. They used the COVID-19 research database to group patients by time of surgery relative to SARS-CoV infection. They take a big chunk of patients from March of 2020 all through to May 30th of 2021 and compare them to surgery for patients who had surgery before January of 2020. And so their results, if you had COVID within 0 to 4 weeks of your COVID infection, you had an increased risk of developing postoperative pneumonia, respiratory failure, PE, or sepsis when compared to pre-COVID patients. 16.8% versus 10.3%. That was statistically significant. If you had your surgery within 4 to 8 weeks from your SARS-CoV infection, you had an increased risk of developing postoperative pneumonia only. And patients who were greater than 8 weeks out did not have an increased risk of postoperative complications when compared to pre-COVID-19 patients. And so again, they recommend, this is as of January 2022, delaying surgery for greater than 8 weeks in patients who have had COVID infections to reduce the risk of major postoperative complications. We have a little bit of data on what we think the impact of vaccination will be on these patients. This is a study, this study came out in February of 2022. This is a study to determine the effect of COVID-19 vaccination on post-operative mortality, pulmonary and thrombotic complications, readmissions, and hospital length of stay. This was an observational cohort study of VA patients from all 155 VAs, and they were comparing patients who were undergoing surgery at least 2 weeks after their vaccine to propensity score matched unvaccinated controls. I will say in this study, they do not distinguish between patients who've had COVID who may or may not have had COVID before surgery. So they had 30,000 eligible patients in total. They matched 3,100 in the vaccination group to 7,400 in the matched control group. The vaccinated individuals were notably were older and had higher comorbidity scores. And they looked at 30-day follow-up. So if you were vaccinated, you had a lower rate of 30-day postoperative COVID infection, but similar all-cause mortality. If you were vaccinated, you had lower rates of pulmonary complications, lower rates of thrombotic complications, but similar rates of readmission, hospital length of stay, and mortality as stated before. And so all of this most recent data has led to the American Society of Anesthesiologists and Anesthesia Patient Safety Foundation to release a joint statement on elective surgery procedures and anesthesia for patients after COVID-19 infection. This was released in February of 2022. And so the decision for elective surgery for patients who've recovered from COVID is based on 2 factors. And so is the patient infectious? And you have to look at based on their symptomatology. Are they asymptomatic? Do they have mild disease, moderate, or severe disease? And so and then based on if they're infectious, that tells you how long they remain infectious. And it's anywhere from 5 to 10 days, up to 20 days in severe critical illness. And so after they're no longer infectious, what is the appropriate length of time to wait between recovery from COVID and your surgical procedure? And again, the recommendation is at this point, elective surgery should be delayed for at least 7 weeks after a COVID infection in unvaccinated individuals. There is insufficient evidence to make recommendation for those who become infected after COVID vaccination. We, of course, have to delay. The delay in surgery must be weighted against the time-sensitive needs of the individual patient. And any decision to proceed with surgery should consider the severity of infection and the potential risk for ongoing symptoms, comorbidities, frailty status, and complexity of surgery. And the second thing that they are asking is, do we need to repeat SARS-CoV testing? And at present, the CDC does not recommend retesting for COVID within 90 days of symptom onset. Once the 90-day recovery period has ended, they are recommending that the patient undergo preoperative PCR prior to the procedure. And if the patient presents within 90 days and has recurrence of symptoms, you should retest them and consider consulting with an ID physician. So as I said, the pandemic continues. We're into January of 2022, where we have another variant, the BA2 variant. that's ongoing. And so the question is, where are we now? So this is data from the CDPHE. Hope you can see this. The top is a graph of the cases in COVID-19 in Colorado as reported to the state, starting in February of 2020 up until most recently, April 20th, when I pulled off this graph of 2022. You can check this every day. You can actually see that our COVID numbers hit the highest in January 6th of this year, where they had 19,000 cases reported on a single day. And our case rate per 100,000 individuals was about 386. At this point on April 20th, April 20th, a few days ago, there were only 833 cases reported per day, and that was about 14 cases per 100,000. In regards to our hospitalizations, you can see the various peaks. Our initial peak was in February. Then you see the Omicron peak, the Delta peak that sort of happened in November, December of 2020, and then the Omicron peak as well. But we're on the way down for hospitalizations. The things that everyone is really closely watching is our daily positivity rate. So on April 20th, which is I think when I took this data from, our daily positivity rate was 4.88%. And our 7-day rolling positivity rate was 5%. And the thing that I was looking at, that I sort of always look at, is how many beds are occupied by our COVID positive patients, and that's 1% of hospital beds in the state of Colorado are currently occupied by COVID patients. Our current UCH COVID testing guidelines. So at this point, given that our UCH average positivity rates are less than 5% for 7 consecutive days, they are not recommending routine pre-procedure testing unless patients have had a known exposure. All symptomatic patients should be tested, and testing should be considered for any high risk or immunocompromised patient. Any patient that requests testing, or if a provider deems testing would be beneficial, should be completed prior to surgery. If the UCH positivity rates go higher than 8%, then we have, for 7 consecutive days, then we will reinstitute testing protocols. In regards to our masking guidelines, as long as we remain in the less than 5 or up to 8% range, we have standard procedures, and the OR, standard procedural and OR protocols apply, and N95s are only required if providing care for patients suspected or have a known COVID infection. And the last thing is our safe surgery scheduling guidelines. So remember, the most recent statement out of the anesthesia department, from the anesthesia groups, is that we should be delaying these for 7 weeks. Our current guidelines, and they're still up for debate, there's a lot of discussion about whether we should change these, is based on the tier and the patient's symptom, and whether or not they're symptomatic if they are COVID positive. And so the delay based on asymptomatic is 4 weeks, and it's up to 12 weeks if the patient had an ICU admission for critical COVID infection. The last thing what I wanted to do is to show you our overall UCH COVID-19 outcomes data. We should all be very proud of ourselves. Overall, UCH has done really well in taking care of these patients. So for our COVID patients and who were not in the ICU, our death rate was 2.35%, and it was expected to be 8.16. As you can see, when we compare to other academic medical centers across the country, these rates are much lower than others. Also looking at the same thing happens for our COVID ICU patients. Same thing, where our death rate was 31% and it was expected to be 35%. And our mechanically ventilated patients, death rate was 39% and it was expected to be 41%. And you can see it's all of these numbers are much lower than other countries across, other academic centers across the country. So to everyone who sacrificed, thank you. And to everyone that took care of the patients, thank you as well. That's all I have, and I was wondering if I'll take any questions at this point. Thank you.
Thank you, Dr. Stewart. Dr. McGee?
Dr. Stewart, great review, and thank you for presenting. I am, as a thoracic surgeon, I treat a lot of patients with lung disease, obviously, and I'm concerned over the recent dismissal of doing routine pre-op testing. We still do it in our thoracic section because of the necessity for long-term outcome. What are your thoughts, especially with the BA2 rise, at least on the East Coast, which will get us? What are your thoughts on routine testing given the magnitude of adverse outcomes that you just showed?
I think there's certainly a lot of debate. I think we're very closely watching the overall community positivity rates and making our recommendations based off of that. Certainly, if anyone's symptomatic or if you're at risk for an aerosol generating procedure, I think it's certainly indicated to test everybody beforehand.
Yeah, I noticed you questioned the delay of surgery, especially in the asymptomatic patients, and it seemed like asymptomatic and mildly symptomatic, it was all 4 weeks, right? And are there really strong data that support that?
I would say the data out there currently is not supporting 4-week delays. Data out there is actually supporting a 7-week delay. Longer.
For asymptomatic?
For asymptomatic, yeah.
Okay. Any other questions or comments? Okay, well, thank you so much. That was a great talk. Thank you. Everyone have a great week.